Before I introduce the next speaker, I'd like to correct a major faux pas that I made. The last gift was not donated by Uinta Golf, but by Utah Imaging, so I do apologize to that group, and I sure appreciate their donation. Our next speaker is Dr. David Mechanic. He is a professor of behavioral sciences, and he's the founder and director of the Institute for Healthcare Policy and Aging Research at Rutgers University. He has a long list of distinguished credentials, which I will not go into, and he will speak about the uncertain future of primary medical care, which obviously is a major and important topic for our current healthcare system. Dr. Mechanic.
Good afternoon. Sorry to interrupt your lunch here. I think there's a growing consensus in the country, as well as in the world, I might say, but particularly in the United States, that all is not well with primary care and it's an endangered activity, and that it's terribly important to redesign primary care for the future, and that if we don't, we're going to be in great trouble. Now, we tend to think in this country as primary care as a doctor, and we typically think of the doctor as sort of the general practitioner or the general internist or pediatrician, and we see that as synonymous with primary care. But in fact, a more useful way to think about it is that primary care is a set of functions that are essential to any kind of healthcare system, and that no matter what, you're going to have it. The issue is how you have it, how it's organized, and whether it provides high quality and effective care. And so as we think about re-engineering our healthcare system and re-engineering primary care, it's important to understand that primary care is a set of functions that can be performed in many different ways by different kinds of practitioners with different levels of skill, and in fact is so as you travel across the world. I mean, there are people who do primary care in some countries with very minimal training, and there are other places that are much like us in developed countries where typically primary care is associated with the activities of a particular trained practitioner. But as you know, increasingly there are lots of different people doing it. And the issue is, how do we take these functions, the primary care functions here outlined, in terms of prevention and first contact medical care, the treatment of acute complaints, adequate monitoring and patient referral when needed, the necessary coordination of care as more and more people are involved in care of a particular patient, with good chronic disease management that's coordinated and effective, increasingly patient involvement in their own care and patient education and support is also a part of the picture. And the issue is, how do you put these things together in a way that's coherent, meaningful, cost-effective, and where both patients are satisfied and the physicians who are involved in primary care can get gratification from their activity and don't feel frustrated and angry about the changes taking place. In the United States, primary care is provided in lots of different ways by lots of different people, as it is around the world. We have, of course, our traditional primary care physicians, generally people in general practice, internal medicine, pediatrics. Some people include basic OBGYN. We have about 100,000 nurse practitioners, and that group of people is growing, and they're playing a larger and larger role, particularly in larger systems. We have a smaller number of physician assistants. Some practice quite independently with the supervision of a primary care physician. We have the HRSA community health centers. The new health reform legislation provides a lot more money for their growth. The HRSA community health centers are supported. They have pretty good bipartisan support and indeed are a growing part of our safety net for people who haven't had insurance or people who have difficulty getting access to the larger healthcare system. A more recent development is the growth of retail clinics, many of them run by nurse practitioners. The estimate is there are about 1,000 now, but they seem to be growing, and one's finding them throughout the country in many, many communities. And I'll talk a little bit about what they do compared with what primary care docs do and nurse practitioners do. Lots of primary care. We don't particularly want emergency rooms to be centers of primary care, but in fact that's where people show up. So emergency rooms end up doing a lot of primary care simply because that's where people come. And then it turns out there's this hidden system of primary care that has always existed, and it's quite big. And that is specialists who continue caring more generally for their patients who they take care of within their own specialty, and who also fill in their schedules if they're not fully booked, fully busy with additional primary care patients who they monitor. The estimate is that there are as many as 400+ million such primary care consultations provided through the specialty system. And this is mixed up in all sorts of different ways in different sorts of settings, and we'll talk a little bit about that as we go on. Now, increasingly, to do many of the things and coordinate many of the things we've been talking about in a way that is satisfying to the physician and to the clinician who does primary care, but who is also satisfying to patients and also is reasonably cost effective given all the pressures on cost, we find increasingly that the way in which physicians in primary care are organized is in some sense discordant with the use of these tools that will make it, will be very important in the future of primary care. Nationally speaking, a very large number of our primary care doctors are still practicing in solo practice or very small groups, and increasingly it's very, very difficult for them to take on all of the functions that are assigned to primary care in the context of a single-handed practice. And many of these individuals, while they go on and they like the independence and they like not being part of a larger group, that there are advantages to them, also feel quite frustrated with what they feel is a treadmill of primary care in these kinds of practices. Now, what are the challenges to the future of primary care? With all the pressures on reimbursement, and increasingly reimbursement being organized, not provided through individual patients, but through large insurance companies or large government programs, reimbursement is a major tension. And primary care doctors are, given all of their educational development and all of that they invest in their careers, receive much lower reimbursement than most other actors, physician actors in the healthcare system. Moreover, our medical school programs generally give primary care relatively short shrift. The teaching environment for primary care is still highly underdeveloped and not very well in tune with what the future is evolving. It is true that over the last 20 or so years there's been large growth in family practice programs and in general internal medicine programs, but generally they are not all that central within the medical school setting, within medical education, and medical education is still largely driven by the specialties and subspecialties, and the message often given to young aspiring physicians is that if they're good, primary care isn't where they should be. So there is a negative message which is to some degree still disparaging of those conscientious and dedicated individuals who really want to do primary care and be part of the primary care system. As I said, given the way in which primary care physicians are distributed, there is a lack of concordance between practice size and practice settings and the ability to organize and use many of the new tools that are available, including the use of clinical teams, nurse practitioners, the use of patient educational materials, the monitoring of chronic disease in a continuous way, the use of IT and electronic health records and things of this sort. And so there's a real difficulty of bringing these tools into the emerging new primary care when primary care is so decentralized and often organized in such small settings. Because physicians have some target notion about what they ought to earn, and because reimbursement has been ratcheted down over time, increasingly primary care physicians feel under great time pressure in terms of meeting patient expectations and patient needs, while also seeing enough patients to generate what they see as a reasonable target income. And as a consequence, they work faster and harder, and they feel they have to see more patients if they are going to meet their target income. And in fact, there's good reason to want to expand the time of patient visits, but the economics of it make it difficult unless there's some reorganization of practice itself and a better use of the new tools that are available. It's very clear that the message from medical school on is that primary care is less prestigious than subspecialty activity. It's certainly rewarded less adequately. And one sort of thing that's been happening nationally is because of the nature of the economics of practice, the need to see quite a lot of patients to generate one's income, the inefficiency of taking care of a few patients in the hospital and disrupting your practice and the time that it takes has led many primary care doctors to withdraw completely from hospital practice. Increasingly, the emergence of the hospitalist has become a growing phenomenon, and more people who are doing primary care spend very little time or no time at all in providing hospital care for their patients. And while that is in some sense highly efficient, it also in some sense undermines the physician's notion about being, in quotes, a real doctor, that is, being able to really deal with the most difficult and most sick patients in a way that they can feel confident about. And as you get further and further removed from hospital care, that sense of confidence erodes. And I say this on the basis of qualitative studies of primary care doctors in which they talk about how while they don't feel they can do this hospital care any longer given the economics of their practices, feel a real loss in not being part of the action in taking care of the sickest patients when they're sick, when they're at their sickest point. So in a sense, we need a new model, a new realistic business model, one that leaves primary care doctors feeling more satisfied and more confident in what they're doing, one that provides more reasonable reimbursement for their tremendous effort, and one that allows them to use their tools and working with others to provide a very high quality of care in terms of managing the bulk of illness in our society. And so that's the challenge. This just tells you what you already know. I apologize for the sort of blurred slide here. The bottom lines all are the income of primary care docs, pediatric docs. The green line is internal medicine. The yellowish line is pediatrics, and the blue line is family practice. And as you can see, their earnings are well below the specialists and subspecialists and so on. And just a fraction of what people make in diagnostic radiology or orthopedic surgery or gastroenterology or dermatology or and so on and so on. So it is a problem, and as a result, more and more graduates of American medical schools, despite an interest in primary care, are deciding to bypass primary care and go into the specialties. Here are some data of changes between 1998 and 2006 in terms of selection of primary care residency positions. And as you can see, there's been a real drop over this period in family practice, general internal medicine, OBGYN, a little in pediatrics, a little in general surgery, gigantic increases in anesthesiology, pathology, diagnostic radiology, and that pretty much tracks the income that these specialties earn. Now, it isn't that we don't have we can't recruit doctors in primary care. Indeed, increasingly we fill those slots with graduates of foreign medical schools. Lots of doctors all over the world would love to come to America and practice medicine, so we can always take doctors from elsewhere. But in terms of the doctors we train in American medical schools, increasingly they are not opting to do primary care. Now, in order to do primary care, given all of the demands, and the demands on primary care doctors have increased very, very substantially. I mean, one of the things that goes often unrecognized by people out in the general community is that we keep on asking primary care doctors to do more and more and more and more in a way that actually, if you sit in a solo practice, in a single-handed practice, or in a small practice, is really impossible to do. Every year there are new expectations. The latest is managing obesity and dealing with children's nutrition. It was sexual health. It was, a few years ago, the recognition of psychiatric morbidity. Increasingly there's the notion of involving patients in their treatment through patient education and so on. That all takes more time than a typical doctor-patient encounter provides, and increasingly physicians, as they try to adhere to these expectations in some reasonable way, feel increasingly frustrated, and of course they don't. They basically don't do many of these things, as the studies show. So how do you do them better? Well, you do them better if you can have a well-organized practice that builds teams to do them in a way where work is allocated to the individuals who are best prepared to do them at the lowest possible cost. And in order to do that well, you need good electronic health records. We need good IT. Compared with many other developed countries, the United States is well behind other countries in getting IT into doctors' practices, getting electronic health records into general primary care. I'll talk about that a little more in a minute. And as you know, there's a tremendous initiative now. The Obama administration plans over the next 10 years to spend $50 billion to try and bring electronic health records to doctors' practices. There will be large subsidies for what they call meaningful electronic health records. The definition of meaningful is still worked out. There's some differences of opinion as to what actually meaningful means, but certainly that's the direction in which we're heading. There's the expectation, the need to, given the gigantic growth of medical knowledge and the explosion of studies and literature and so on, there needs to be a better way of integrating that information and providing it at the point of service for physicians in a way that's meaningful and useful and effective and helps them make good decisions. Increasingly, to do these things we're expecting primary care to do, we really need organized teamwork. We need good collaboration, effective work teams with physicians, nurse practitioners, PAs, other kinds of health technicians, medical educators, the whole range of people who are now nutritionists, who are now involved in meeting the expectations of primary care. Well, obviously, the economics of small practice don't allow that. You need a fairly large practice base to be able to support and organize this kind of care. And increasingly, to the extent that practices remain very small, it's going to be very, very difficult to implement. Good care, excellent. All physicians want to provide good care, and a lot of physicians generally believe they are. They're doing the best they know, and they feel that they're doing a good job. But you can improve your job if you get good feedback in an appropriate way at the appropriate time. And we know that good, effective clinical feedback as to one's performance relative to one's peers is a useful way of changing and helping direct practice more effectively. Once again, unless you have a decent IT system, unless you have a well-organized infrastructure for that system, it's very difficult to provide the kind of feedback that is meaningful and helpful in making better healthcare decisions. And increasingly, we say that primary care doctors must manage chronic disease more effectively. And most patients have long-term chronic disease. Many of them are treated episodically, and they end up going into crisis. They end up being admitted to inpatient care unnecessarily. They leave inpatient care. They're not followed up appropriately, and they get into further crises. And now the expectation is that we have to manage those illnesses, heart failure, cardiovascular disease, asthma, diabetes, much more effectively on a continuing basis, so we avoid those crises, those unnecessary hospitalizations, those difficulties that clearly are preventable if we monitor them. Now, a typical traditional primary care practice doesn't, and physician doesn't really know who all of these patients are and what the status of their illness is. In order to do that, you have to be able to maintain patient registries by condition and be able to monitor those patient registries so you know whether patients are coming back, following up, filling prescriptions, doing many of the things that are necessary to maintain good chronic care. These tools, the tools that I've been talking about, help you do that much more adequately. And the issue is, how do we get to the point where all primary care practice can utilize these tools and utilize them effectively? Now, generally, there are sort of, in the studies that are being done of the adoption of IT, people basically divide the functions into basic systems. And actually, many of the practices that have IT simply have them for billing purposes, not really for clinical care purposes. And so they basically have divided them between the basic system and what they call a fully functional system. There are some organizations that have fully functional systems. These are some of the model multi-specialty groups I'll talk about later. Places like Geisinger Clinic, places like Health Insurance Plan of Puget Sound, Kaiser Permanente, the Veterans Administration, who have pretty well-functioning IT systems that have been developed over some period of years. In many of the small practices, we see just fragmentary systems that do a couple of things, but don't do many of the things that IT makes possible. So this is just one study from the New England Journal that makes these distinctions and simply characterizes some of these activities as basic and some of these as a more fully functional system as a way of looking at what's happening in terms of implementation. And basically, for the most part, American physicians are not very well wired. They're living in a prior age in terms of IT. In primary care, according to this recent study in 2007-2008, only 6% of primary care doctors had available to them a fully functional IT system, and another 15% had a basic system. Specialists are no better off. In fact, they're even have a little less IT in their practices. Although one could argue that IT is more important for primary care than it might be for a subspecialist who is doing a much more narrow set of activities. And as you can see very clearly, and as everything I've already said would suggest, it's related to practice size. That is, the larger practices are much more likely to adopt an IT system, and about half of them now have some kind of IT system, but only 17%, even of practices of more than 50 doctors, have a fully functional system. So we have a long, long way to go, and we obviously have to accelerate that. I mean, if we just let this evolve as it's been evolving over the last dozen years, we're going to have to wait many decades before we have a decent IT system in place. And that's one of the rationales for the federal government spending $50 billion to try and accelerate this trend. We now, as you know, have I guess the press calls him the IT czar, David Blumenthal, who is a general internist at Mass General Hospital and Harvard Medical School, a very fine person who's obviously working very hard with many others in this arena to try and define reasonable expectations in terms of what is effective IT and help move the system more quickly than it's been moving up to now. Here's a recent study done through the year 2009 by the National Center for Health Statistics, which has been tracking this. And according to their recent study, 44% of physicians in the United States in office-based physicians had some kind of IT access. Some of it was very limited, let's say, just for billing type things. However, if you look at how many have the basic system is defined earlier, you only have about 20% with the basic system and only 6% with the fully functional system. Some people think that the fully functional definition will be the definition of what is meaningful under the big subsidies that are being provided under the new health legislation. Perhaps it will be a piece of that. It may be too much to expect physicians to rapidly move to these large functionally fully functional systems. You need a lot of investment to do that. Kaiser Permanente, which of course has 7 or 8 million people, has invested literally billions of dollars in their IT system. It could be very, very expensive. In addition, I mean, one of the real problems in small practices is their startup time. You bring an IT system in and you have to learn it. It slows you down. It changes your pace. It changes your practice activities. If you're sitting there by yourself, you don't have an IT staff. You worry if there's a breakdown, if your computers go down, who's going to help you, who's going to straighten out the mess. So there's a lot of anxiety and concern, particularly among people in small practices, about having the kind of technical backup that they feel they will need if they're really going to make the conversion. And that creates a lot of anxiety and a lot of concern, and explains why people have been so slow in the United States in picking up on this kind of IT, EHR type solution. Now, I want to move now to this other issue, which is the issue of doctor-patient encounter time. If you talk to doctors, and I talk a lot to primary care doctors, they just complain that they don't have time to take care of patients. That's their biggest complaint. They feel like they're on a treadmill. They just have to move faster and faster. And their notion somehow is that there's less time. And people have interpreted that to mean that they're spending less time with patients. But in fact, if you actually look at the data show that in fact the actual time doctors are spending with patients is increasing slightly rather than decreasing. What has changed, and changed dramatically, is the expectations of what we expect doctors to do during those encounters. Life has changed dramatically within that 15 or 20 minutes. Patients come and they're more assertive. They've looked up their illness on the internet. They have all these questions. They're now bombarded by direct-to-consumer advertising. They see stuff on television. They want a drug, and you have to assess and perhaps persuade them that they really don't need that drug, and that drug is not good for them. You have all these new expectations about things you're supposed to manage: obesity, depression, and so on. And as a consequence, within that same period of time, or even a little more time, you're doing more and more and expected to do more and more, and you feel more and more hassled. And that's what doctors seem to be experiencing. The actual data is that they are spending more time with patients, but not enough time. That is, if you do the things, and now these new models of medical homes and so on are finding that if you really do the things they say medical homes are going to do, your encounter time has to be more like a half hour, not like 10 or 15 minutes. And the issue is, if you're going to realistically spend a half hour with a patient, given the reimbursement as it's now structured, you better have a way of organizing that practice so that you have less patients demanding to see you whose problems are being dealt with in other ways, whether they be ways using electronic health records, whether they be through nurse educators or health educators, whether they be with the help of nurse practitioners. That is, you need another way of organizing ones, whether they be through group visits, whether you need other ways of organizing your practice so that when you're seeing patients who really need your time, you could really spend that time with them and do a good job, a job that they're satisfied with, and a job that you're satisfied with, and feel you're really providing good communication and good care for that patient. But under our present business model, it can't be done. It's very difficult to do, given all the changing expectations and the changing forces affecting medical care. I just do this to sort of point out that this is not unique to America. These pressures of more treatments and more options and more activated patients with more demands, that's happening in all developed countries. This primary care problem is a problem everywhere, although some countries have invested much more in trying to build their primary care structures. In the UK, the average time over time has been going up. The National Health Service has put into play, has almost all GPs in the National Health Service wired with computer systems where they can do many of the things we talked about as fully functional systems. They've invested enormously in building those IT systems. They have pay-for-performance systems which substantially reward physicians for meeting clinical goals, and indeed the evidence is that clinical goals have been surpassed far beyond what they were expected or were aiming for, so it's cost them a lot more money than they anticipated. But the physicians are responding, the GPs are responding to those kinds of incentives. As you look at care, primary care through European countries, you find that there's a lot of changes in the way these practices are being organized in terms of using nurses and using education and these all kinds of alternatives. And actually, the recent data from the United States indicates that, for the most part, while a few doctors here and there are doing these things, for the most part, American primary care doctors are not. These are the simplest ones. They're much more complicated ones. But for the most part, primary care doctors are not doing these things. That is, only 3% have used group visits across the 4 conditions here: asthma, congestive heart failure, diabetes, and depression. some more. If you have 1 or 2 conditions, 16%. But still, the great majority of doctors aren't doing these kinds of things. Very few practices have non-physician educators to deal with nutrition and all of the other issues of chronic disease management. There is a growing use of nurse practitioners, but not the heavy use of nurse managers to help coordinate care for chronic disease. The one thing that's the easiest to do is hand out written educational materials, and many more do that, but even they're a minority, us doing that compared with the majority. So we have a long way to go if we're going to bring some of these new ways of reorganizing, redesigning practice in a way that takes some of the load of unnecessary visits off the primary care physician and then allows the primary care physician to spend their time with those patients who really need that time, really need that one-to-one, face-to-face time for longer than the typical primary care visit. In thinking about, if you think about sort of a lot of different people doing primary care, there are theoretically many kinds of redesigns that can be done. If you look at these major chronic diseases, these major problems, most people who have them see both a subspecialist and also a primary care doc. And as I said earlier, millions of visits that are very basic care are being provided by the subspecialists as part of their subspecialty activity or in conjunction with that, but not necessary, the primary care activities. And perhaps with some careful redesign in better organized groups, a lot of that care can be shifted from subspecialty care back to primary care. And then other things that primary care doctors do that don't really require their level of training and preparation can be done by others. And one sort of example is these new retail clinics. Now, when you talk about retail clinics, that's what they are. They're organized commercially by corporations like CVS and so on, Walmart. But it could be a set of functions. It could be part of a practice. It doesn't necessarily have to be a commercial clinic run for profit. But basically, it's the basic notion that there are a lot of very simple, established things that primary care doctors do that a good nurse can do quite as well. There are hundreds and hundreds of studies showing that for these kinds of things, nurse practitioners are as good or better than primary care doctors because they spend more time with the patient. Patients feel more willing to ask them questions. They're less threatened. There's less of an authority distinction. In any case, if you really look at what these retail clinics do, 90% of what they do are the very common, everyday things that primary care doctors don't really have to do themselves. They can be done by somebody else. And actually, if you look at what primary care doctor visits are compared with the retail visits, only about a fifth of the visits that primary care doctors themselves do involve these kinds of direct activities as compared with their nurse or somebody else. A lot of the people who go to retail clinics up to now have been people who don't have insurance. They're less expensive and they're immediately available. There's no waiting time. You just show up. And so patients seem to like them. But in a way, separating them from primary care practices is not a good thing because it sort of breaks up the continuity of care where the coordination is less good, where the primary care doctor doesn't know exactly what's happening in terms of prescriptions or immunizations in this other place because they're not part of their record system. So the idea is to bring these functions together in an organized way that are held together by an electronic health record so that all participants know who's doing what and what's being done, and you can monitor that over time. It's easily said. It's very hard to do. I appreciate how hard it is to do this. And it's taken some very well-organized groups with very good physician leadership to do this. There are some dramatic places that have changed impressively in recent years. The Geisinger Clinic in Pennsylvania has been doing extraordinary innovative things in terms of redesigning primary care. A place I've never visited, but I keep on hearing these glowing stories, is an outfit in Seattle, a Virginia Mason. And the docs who've been there to visit tell me it's just fantastic in the way in which they've organized their practices in efficient, effective, high-quality ways. And there are many such places now emerging, but they're still a tiny minority of what's going on nationally. So what do we need to sort of make changes? Well, we have to have a better reimbursement system, a fair reimbursement system. We really have very high expectations of primary care, and the differences between what we pay for talking to patients and managing patients versus what we pay for sticking some gadget in someone is very, very large. And therefore there's a great incentive to stick gadgets and do tests and procedures, and much less incentive to talk to people that you don't get paid for, or to manage care when you don't get paid for managing care. And also we have a system, as everyone knows now, it's become sort of everyday talk. We have a system that simply pays for doing things rather than pays for good performance, effective performance, enhancing people's health. So there's a big push now to try and develop reimbursement approaches that reward people for providing good, effective care, measuring that care, and then basically paying for performance. And the new legislation passed, the health reform legislation, involves a new agency to study health innovations, and we're going to have a lot of demonstration studies of some of these things to really figure out if they work and how well they work and so on. We know they've worked in particular places that are these sort of star clinics around the country, but the real issue is how do you get what works in some of these star places to the everyday clinics all over the country. And so the issue of transferability, the issue of diffusion is a very big issue, and we don't really understand how to do this, although everyone wants to do it. The basic idea in re-engineering primary care would be to reduce the pace by reallocating functions and have more time for direct patient care for those patients who really need that time. And that involves effective use of teams and coordinated care processes. Once again, that's more easily said than done. It's sort of hard to get a team to really work harmoniously together, and you have to work at it. And it takes commitment on the part of all members of the team. And a lot of these large group practices that have done this really have invested a lot in making these teams work. This is true, I mean, not only in primary care, it's true throughout the whole system. There's a very innovative anesthesiologist at Johns Hopkins, Provenost, you've probably heard of him. He's published in a lot of the major journals, who has been interested in catheter infections and reducing them, and has developed a teamwork approach, including the list, which has been given a lot of media prominence, but team approaches to basically eliminating catheter infections in intensive care units and surgery, and they've had dramatic impact in reducing in many places to almost zero the catheter-induced infections through excellent teamwork and excellent monitoring and so on. So it's a more generic problem. It's not just the primary care problem. Obviously, if we're going to expect primary care doctors to develop medical homes and to do care management and coordinate and so on, we have to pay for that just like we pay for procedures. So there has to be some reasonable reimbursement system that takes into account the value and importance of doing the management and the coordination. I've already said enough about EHRs. We have to sort of have a stronger evidence base And basically in doing that, it's terribly important for physicians to buy into that. You can't impose it from the outside and expect it to really work. And we know that a lot of these practice guidelines don't work, they're ignored, and so on. The issue is to sort of develop cultures within medical groups that get physicians involved in and to buy into the effective use of practice guidelines. And one way of doing that is at the same time protecting the autonomy and clinical discretion of physicians to deviate from those standards when they feel the circumstances or particular issues involving that patient merit it. But it has to be a system that's accountable, where that physician can basically explain these non-practice guideline activities in a way that is acceptable to the judgment of the peer group, other physicians they work with, and so on. And of course, the hardest business is building these cultures. And when you get a big group of people together in a practice, I mean, it isn't the trick isn't to have a multi-specialty group practice. The trick is to have one that functions harmoniously and effectively with innovation and commitment and so on. And it's easy to put together the pieces. It's much harder to develop the culture. The places that really work well, the places that we see as our sort of dramatic examples that everyone's writing about, are places that have had really superb medical leadership and that really have developed a culture. Studies of primary care indicate that many physicians in larger groups feel their practice culture, their practice organization is dysfunctional. So it isn't enough to have a larger group. You really have to have a larger group that is built around a solid set of norms and understanding and mutual respect and dignity for all participants. And that is something that doesn't happen overnight. I've written a critical piece recently in JAMA where I point out that everyone's pointing to these places like group health insurance and Kaiser Permanente and Virginia Mason and say, you know, that's what we have to do. But those places have developed their culture over a long period of time. They didn't develop that culture overnight. Mayo Clinic, Cleveland Clinic. There are many of these organizations around the country. But these organizations didn't evolve overnight and just you slap it together and you created this kind of culture that works so well. There's a lot of tension now, as you know, in the literature to something that's called accountable care organizations. Since we know that physicians generally will continue to practice in smaller groups and you need larger networks to make these things really work, people who have been pushing this accountable care organization idea are talking about putting together different existing groups and evolving them into a virtual network, things like IPAs or hospital physician organizations, organizations of that sort. But it's one thing to sort of develop a strong culture in a well-organized medical group, but taking a hospital physician organization and evolving into that isn't going to happen quickly. It's going to take lots of pain and lots of time and lots of effort and lots of leadership. But indeed, if we're to get there, that is what we have to do. And it's not going to happen tomorrow. I mean, I think a reasonable timeline for this is 10 to 20 years before we really even get close to what it is we're aiming for. Okay, well, obviously, it's a lot easier to do in a well-organized, large, multi-specialty group with strong primary care. And this is why it works so well at a place like Geisinger or Virginia Mason or Mayo or Cleveland Clinic or the Marshfield Clinic. They have very well-organized multi-specialty group settings. They have the IT systems in place, and they have good leadership and have historically had good leadership, and they have, in a sense, a way of evolving into the kinds of systems we would like to see nationally. Here in Utah, you have the Intermountain Healthcare Medical group care model, and particularly their medical home model, Management Plus primary care medical home model. You're probably far more familiar with Intermountain than I am. I could just tell you they report in their literature, with careful studies, that this kind of design leads to lower rates of hospitalization, leads to more satisfied patients, leads to reduced cost and higher quality care. And all of the data on all of these systems indicating that as a consequence of putting the kinds of systems I've been talking about into place, they've been able to get pretty good results for different populations. In some cases, it's just an elderly population. In some cases, it's a Medicaid population. In some cases, it's a more generic population. But generally, basically, putting into place strong, continuing chronic care models for patients who are at risk, monitoring those patients, making sure they get the care they need, and avoiding exacerbations and episodes of hospitalization, good follow-up following hospitalization, and so on. And of course, we're now talking about changing the reimbursement system in significant ways that begin to provide incentives for doing these things. The big term these days is bundling, paying for a whole episode of care from hospitalization to post-hospitalization. And there will be there are demonstrations in place that CMS is running on bundling. There will be more under the new reform legislation. As I mentioned, people are trying to develop these accountable care organizations. That's a harder challenge because, in a sense, you have to create the culture and deal with all of the tensions and antagonisms among hospital and community physicians, among specialties, fights over remuneration and relative remuneration. These are not easy issues to resolve, and it's going to take time to resolve them. But I think in many ways we are thinking about a more productive kind of future. There's no question things will have to change. The issue is how long it'll take and whether we can effectively speed it along so that patients are getting better and higher quality care, and the clinicians who provide it come away with a greater sense of satisfaction and a good feeling about their lives and their professional activities. Thank you.
So from what you say, do you think that primary care is not dead then?
Well, I think my basic point is it can't be dead because you can't do medical care without primary care. The issue is who does it and how is it organized. But the functions, whether you like it or not, the functions have to be performed by somebody. Following Mao's death, I was in China on a rural health care commission, and we went to these rural villages, and there were people with 3 weeks training doing primary care. And they did a lot of valuable stuff, although they were obviously not very well trained. I've been to Latin American countries where people with very limited training were providing much of the care much of the primary care, or nurses largely in many of these countries provide much of the care in rural areas and so on. So the functions will be done. I mean, there's just no question about the functions being done. Not all the functions, not good management and so on, but providing prevention, doing immunizations, dealing with acute problems, sending people who need more serious care to hospitals. That will be done by somebody. The issue is whether we can do it well or do it badly.
Question about the IT systems. Harvard's been using an IT system since 2002, and we're now looking at what we need to replace. And has any thought been given to organizing this problem around large servers off-site, available connected through the internet so that a system that's effective and useful could be made available to all and be made more seamless between the various groups that need to interact?
Now, obviously, one of the things we would strive for is interoperability and seamlessness and so on. As I'm sure you're aware, there are extraordinary concerns about privacy and protecting privacy and providing protections both under HIPAA, but more generally as these systems take place. Some of it's paranoia compared with what really happens with paper records, but in any case, they are very serious issues. I'm sure that, there are a lot of very smart people working on this, and I don't regard myself as an IT expert, and I'm sure they've thought of lots of things, cloud computing and all that sort of stuff. But Harvard has a very good IT group. There's some really terrific people who have worked on this over many years at Harvard. But it's a really tough problem. It's even tough to get a good IT system into a particular clinic organization like Kaiser Permanente, a group health plan. But when you talk about the interconnection between hospitals and emergency rooms, and people are even talking about retail clinics being part of this system, you're talking about lots of issues that people get very sort of concerned about. And I don't know all the ins and outs of these so-called privacy protections and how good they are. But my feeling is, we use these systems for our national defense. We use these systems for our whole financial system, for our utilities grids. We depend on these systems for almost every other sector other than medicine. And we've developed what we hope are good protections of those systems. There are lots of people who would like to bring those systems down, as you know, in terms of terrorism. So I have some confidence that these are solvable problems as we move to increase the interoperability of those systems. But I don't pretend to be an expert on the IT, aspects.
As you pointed out, one of the drivers was economics, and when I was in my internship, the family practice doctors got the word well, and the internists, and I don't want to be in politics, the internists got the train wrecks. I'm a psychiatrist, and now that primary care does most of psych, I get the most difficult things. And we can talk about the long run, but we live in the short run, which is the now, and you're giving primary care harder and harder patients now with no reimbursement and the same amount of time. And you say, so what do you do in the now? I look at, I love when I get a psychiatric sore throat, but mostly I don't.
Well, that's part of the big issue now. We have basically made psychiatrists psychopharmacologists. Very few psychiatrists now spend their time doing psychotherapy. It's very poorly reimbursed in our managed mental health system, and as a consequence, they don't do that. Almost all the psychotherapy is now being done by social workers, some by nurses, and then about half of the system is just dumped into primary care. And as I said earlier in the day, we know that most antidepressants, most anti-anxiety drugs and so on are being prescribed by general physicians, not by psychiatrists. And we also know that the most of that care is not meeting practice guidelines as established by the psychiatry profession. So that's where we are, and changing that's going to be very difficult because the economics really militate against it, and also there are tremendous outside forces, including the pharmaceutical companies that sort of promote primary care doing a lot of this stuff because those are the doctors they can reach most easily.
Not to mention the turf issues that happens when you take away from one specialty. Reducing care to the procedurists, the gadget putters, as you put it. Conflict comes when the doctors, and then we stop dealing with the system. So, I don't want to sound like Cassandra, so I'll sit down.
Well, we know that the fights when you try to work out the reimbursement under our present arrangements in the Medicare program are quite vicious, with each specialty coming in to defend its turf. We're going to have to overcome that in some way. I have no great ideas about how to overcome that. It's going to take a lot of hard work, and perhaps some strong push from various forces both with and outside medicine.
As a primary care physician, we see a lot of the insurance companies having initiated some of these care process models, sending us reminders which patients need to be on an ACE inhibitor, very duplicative and I'm sure expensive at their end. And yet, at one level, it's a good idea. I'd be curious your thoughts as to what entity might better serve us to disseminate these informations, whether it comes from within ACOs or within an insurance company, or whether it should come from the federal government.
I would myself like to see it coming. I mean, one of the problems with a lot of these practice guidelines is there are a lot of interests developing them in their own interests. So I would like to see them come from sort of physician expert groups that are not single specialty groups, but basically who understand the issues, understand the literature, and can develop these practice guidelines and give them credibility and legitimacy. There's one point at which the federal government tried to do this some years ago, in which they basically contracted with medical schools that were specialists in different areas like back pain and cardiovascular disease and diabetes to really try to develop the very best practice guidelines, which then could be used in these kinds of systems. And there's one in particular, there was one in Seattle at the University of Washington, a group on back pain, which after they reviewed all the work and all the studies, came out with the conclusion that an awful lot of back pain surgery was unnecessary and indeed not useful. And the spine surgeons organized to eliminate the agency, and indeed almost succeeded. At the time, the agency budget was cut by more than half. After Senator Frisk helped save it at the time, it would have gone down. But the agency continued. They changed their name. Now they're the Agency for Healthcare Research and Quality, and got new leadership. They've brought in at the time John Eisenberg, who was a professor of medicine at the University of Pennsylvania, and he did a very good job in redesigning the agency, but they got out of this business. And the issue is, who can do this? And I think the general feeling is if the feds do it, or if the feds do it within the federal structure, it's going to be exposed to a barrage of lobbying, and as it is, the Congress then intervene when they're lobbied and try to change things. So there's a real concern that this be insulated in some important way from the everyday political process. And that's, of course, the big issue with clinical effectiveness research. We're going to spend vast amounts of money now to do clinical effectiveness research and then set standards on that basis. And there's a real debate as to whether that is better done outside the federal government by some kind of agency like the Federal Reserve, something that's more insulated from congressional pressure than government bureaucration. But there's a real problem as to where you actually put that. My own view has been, and the view I've taken in writing, is that it should be an agency that is insulated as much as possible from the political process, so that it is not dependent and will not succumb to strong lobbying by the interests.
This is just a comment that hopefully will be helpful to many of the physicians here in regard to electronic medical records or information technology as it applies to your medical records. Many of you received a couple of weeks ago a little flyer in the mail that had a copy of the picture of the Golden Spike driving on May 10th. Any of you remember receiving that? Because I know many of you did. That's very interesting because I know they were received. On May 10th, last Monday, Health Insight and UHIN, I'm I'm trying to think of they drove the spike. Anyway, they began their kickoff on a new program for electronic medical records and information technology for Utah that all of you can take advantage of to get assistance from them through the Utah Medical Association or directly with UHIN, which is where all of your billings and payments come through currently even, to help you upgrade or install if you don't have an electronic medical record system. And that system is currently, as it's being kicked off, and it will expand, will include some of the things that were mentioned, like trying to integrate information from your patient goes to Dr. A for whatever reason, then comes to see you, Dr. B, and you don't have that information other than a little word of mouth from the patient. That information will be available to you through your electronic medical record, and that is happening now in Utah. And so I would suggest you get a hold of the people at the Utah Medical Association or UHIN or Health Insight to help you get on board with this. There are also financial grants available to you to help you implement this.
Just a quick comment too. Not 5% of my patients take up 95% of my time, and now that they're taking, so it's kind of nice to see a sore throat on a really busy internal medicine day, and now all those are driven to these retail clinics. I mean, how can we increase the amount of primary care so we all have a little bit of everything rather than, have, the retail gets the easy stuff and then the family practice gets, or the internal medicine gets the train wrecks. I think, primary care should be a spectrum, not just, retail and then regular primary care. I don't know how to fix that.
Well, once again, there is some real efficient function in, I can see the value of doing everything with the patient, so you get to use that as a way of getting to know the patient getting to know you, and developing the kind of rapport and communication that makes for good primary care over the long run. But I think in terms of any kind of business model, doing those more simple things are better left to someone else in the practice with some involvement of the primary care physician. I don't like the idea of the separate retail clinic. But in a sense, every practice of any size can develop its own sub-organization that does this in a way that is equally efficient, and perhaps has to be efficient from a patient point of view too. That is, if you wait 5 minutes at CVS but have to wait an hour and a half at the doctor's office, that's not going to work. And make that part of the whole practice, and the patient comes to see the whole practice as its team and not just the doctor. But I think in a sense, cutting off some of the simple things is one way of having more time to deal with the more complex things.
Thank you.
Thank you very much, Dr. Mechanic. The next session starts at 2 o'clock around the corner, or those of you who have signed up for the skills labs, you can find the area where the skills labs are being held in your program. Thank you.